Good afternoon, everyone. This is Sarah from Better Health Together, and we are glad you joined us today for this webinar on integrating behavioral health in primary care. We are very grateful that Mark from Providence has joined us. He is their integrated behavioral health supervisor, and I'm going to hand it over to him. Please feel free to raise your hand or use the chat for any questions or clarifications as we go along. And I will also here briefly post in the chat a link to the slides if it's helpful to follow along there. All right, Mark, over to you.
Well, hello, everybody. Welcome, and thank you for Better Health today for giving me this opportunity to come talk to you about a little bit of what we're doing over at Providence. A little background about me, grew up in the Seattle area, came over here for graduate school, and then have been here ever since. Worked at community mental health for the better part of 15 years, doing crisis work. And then in 2017, moved over here to Providence and started doing some of the primary care behavioral health treatment I'm going to talk about. So it's a little bit about me. So I figured we'd talk a little bit about kind of our roots here, what we started with, how we started, give you an idea of what one of our care managers experiences during a day of work. So one of our staff has graciously agreed to talk about that, give us some information there, and then talk about kind of how we, what we learned, how we were able to flex and adapt and pivot once this pandemic came, which I think most people in all of healthcare, not only behavioral health, but really had to look at some ways of doing things and some ways of being flexible and those sort of things. So we'll talk a little bit about that, what that adaptation looked like, how we've been able to meet some of those needs, how we're continuing to try to do those things. But I figured I'd start out with just an understanding of the treatment that we're providing in the 7 primary care clinics currently in Spokane and Stevens County. Those are the primary care groups through Providence that have this model inside of them right now. There are plans to expand that, but currently that's where we're at. So I got really interested in this type of treatment because I read it in a book in 2002, 2004. What did integrated care look like? Well, until I saw this model, I really didn't see that there was an actual integration, a collaboration in treatment with behavioral health and medical providers, and RNs and medical assistants. But this really provided a good model understanding of kind of what it read like in theory back in the day, and now kind of able to see it up close and personal. So that was really exciting for me. So really trying to understand the access. I think everybody recognizes behavioral health access is an ongoing journey, something that we all always try to meet. Making sure treatment is effective, making sure it's appropriate, being able to measure it is important. Recognizing the mortality gap, which we'll talk about a little bit, especially important working in the medical community, and then assuring that what you're doing has some evidence behind it and has been worked and tried before and has had positive results. So this model of treatment actually started before I got to Providence, and I want to call out Doctors Tanya Keeble and Amy Burns, who started this program in 2015 in the psychiatric residency at Spokane Teaching Health Clinic. And then it moved over to the first primary care clinic when I started at Internal Medicine, McClellan, which is right up next to Sacred Heart, just right at the hospital. So trying to recognize these challenges and figuring out how we provide a solution to those. And looking at these four things, the treatment on paper and reading about it, getting training, it really felt like it met most of those goals that we talked about. One of the things that was helpful building these things out is when we started program development in the primary care, we actually had University of Washington AIMS program on site for us in the clinic with us day to day for a week. So that was super helpful to get things off the ground. So recognizing that we want to make a difference in the overall population of the medical clinic. So it's not about, recognizing specific types of illnesses or specific social determinants of health, but we want to make a difference in the overall behavioral health profile of the medical clinic. So being population-based means that we really kind of lean on a shorter term product, shorter term treatment, seeing patients for maybe 3 to 4 months, very focused, very skill based, and positioned to really notice appointment to appointment how their symptoms are going and hopefully moving towards a relapse prevention. One of the ways that we do this that I'll talk about in a little bit is by a registry. So keeping track of all of our patients, the last time they saw us, their depression at that time, the difference between their symptoms when they first saw us to now seeing us, so we can see a difference. And also recognizing when we have utilized the psychiatric consultation component of this treatment, which is also supports it in being able to be a shorter term based program. So treatment to target really all talks about this registry that we keep track of, and we measure treatment. We weekly, alongside of psych consultation, review every patient, sort them, filter them based on risk, based on weeks in treatment, based on depression, anxiety scores, to really see kind of where everybody sits and to assure that we're continuing to go in the direction of stability. And this is not to say that self-determination and the patient's ideas on treatment are not important. It's just another way. This is how I explain it to patients. Yes, we do these psych screening scores, but most importantly, how are you feeling? What are you noticing in your symptoms? And that gets to the next point, being patient-centered, recognizing that yes, we have a treatment model, and yes, we have roles in that model, but we really want to know what their goals and objectives are for life. And we want to position ourselves behind that, not only myself as the care manager, but also the primary care provider and the psychiatric consultant. So recognizing their agenda and going in that direction is important. As you can see there, it does look collaborative. So the patient's in the middle. The medical provider has ongoing treatment or contact with the patient. In fact, the patient comes to us because of the trust in that relationship. They trust their physician, they trust their medical providers, and the medical provider develops a trust in us and the psychiatric consultant. So all of us are aware of where the treatment's at. All of us can access the registry. We continually maintain contact through electronic medical records. So that collaboration and transparency is really important in this model of treatment. And I think all anchored by the registry, where we can really take a look at where treatment is currently and where it was in the past. This gives you a little picture of what the registry looks like. Initially, we started out with an Excel spreadsheet, but as time has gone on, University of Washington has developed web-based products, and that's currently what we're using right now. So it looks very similar to this, where we can access through security measures into the portal on the web. We can get the patient's name and quickly see where they're at in treatment and how things are going. We can drill down to all of these sections and find out when their appointments were, demographics, the days that we did psych consultation. There's also note sections that we can utilize. I can tell you in my profession, going forward, I probably would not want to work without a registry. This product and tool really helps us to maintain accountability and to assure that patients don't fall through the cracks. So this gives you a little idea. I talked about 3 months, maybe a year at the very latest. Intakes are around 90 minutes, rapport building, counseling sessions, 30 minutes to 45 minutes. Again, very specific. Cognitive behavioral therapy, acceptance and commitment therapy, dialectical behavioral therapy, behavioral activation, solution-focused therapy, any therapy out there you can think about that's brief and that has skills the person can develop and can notice themselves developing them through treatment. So frequently homework, frequently reviewing that homework at the next session, collaborating with the patient to see progress and notice when they're feeling better, and then getting to relapse prevention. What are your triggers? What are the times, places, environments, people that provide symptom triggers, and what skills should we utilize when those come up in the future? We probably all heard the idea of eventually becoming your own therapist. Well, this is kind of along the same lines. Is really developing those skills so you feel comfortable, they become second nature, and you have a toolbox, for lack of a better term, in the future if your symptoms deteriorate, and you can grab from those that you've learned. On the bottom, you see medication management. Currently, we're utilizing the psych residency at Spokane Teaching Health Clinic. And we'll talk a little bit about where that's going from now, but currently that's the psych consultation service that we're utilizing. Just giving you reasoning why this treatment is helpful. Just some studies. The one on the left-hand side here gives you a comparison of usual care, which we know that behavioral health is accessed in primary care. That's the highest place that most people go to access behavioral health care is their primary care provider. So this shows you the difference between usual care and integrated care. And you'll see 50% decrease, savings of over $3,000, impacts to A1Cs, blood pressure, emergency room visits. Stigma is a big deal. They know their doctor. They've been to the office. They have a relationship. Rapport has been built and trust has been built. And so it works really well to go to your doctor's office and see a therapist. And what we've noticed from that is that patients feel really, really comfortable doing that. So other reasonings, why is this treatment important or effective? Physical health. There's been a lot of studies, I'm not going to go over those today, but correlations between improved depression and improved diabetes, improved blood pressure, heart disease, those sorts of things. Resources. Lots of times people don't know where to find a therapist. They don't know what their insurance takes. They don't know where they're located. So we're trying to take some of these barriers away and be set up in a place that they know and that they're comfortable with. And this is just more information, kind of what I just discussed and some of the benefits of this treatment through time. And this model of treatment called collaborative care from the Ames Department at University of Washington is nationally recognized now and spreading around the country. This just gives you an idea of a clinic that has integrated behavioral health and one that doesn't. Just gives you an idea of the depression profile, how much depression these primary care clinics has. You can tell here that the ones that had integrated behavioral health had way less depression rates than the ones that didn't. Primary care providers, what we notice is that they really like this program. Having behavioral health support, having medication management support in the primary care, I think has been something for a long time that's been sought out in the primary care setting. What we find is that most providers are very satisfied with it. Gives you a couple quotations here. The one on the bottom is a little dramatic, but we'll take it. So here's kind of a typical day. So you think about your regular behavioral health provider out in outpatient, community mental health, private practice, standalone outpatient, inpatient. There are a lot of behavioral health providers out there. This gives us a little bit of a picture of kind of what it's like on a daily basis for our clinicians in primary care. And this is specifically from one of our staff that was nice enough to give us information on what her days look like. So obviously probably all of us are working with electronic medical records. We are scheduled patients just like the providers are. So we have one patient after another that we see during the day. We see each patient and think about what skills, what their goals are, what their depression screening, anxiety screenings have looked like. That's some of the things that she does every day, is really kind of assuring that she has all the tools that she can utilize in the clinic, not only to go over what they practiced last appointment, but also to think about some other ways of decreasing those symptoms. So a lot of your appointments, you think about typical therapy appointments, sometimes at an hour. And some of that can be talk therapy, some of it can be psychotherapy. A big portion of this is practice. So practicing in your environment where you hang out and spend most of your time, how would this skill work? How would you utilize it? And when you tried it, what happened? So really getting a good idea of the skills that work for the person, the skills that don't work, trying to suit the specific skills for the patient. When bringing a patient in, we talk about sleep, talk about medications, teach new skills. One of the things that's a little interesting and I guess different to typical social workers is that we tend to gain knowledge about medication management. You can imagine a full-time staff spending an hour or two a week with attending psychiatrist and a resident a resident becoming a psychiatrist, learning about medication management, learning about impacts of labs, and gaining a lot of information medically and for medication management. So while we, of course, don't provide recommendations or tell patients what to utilize or anything like that, that's above our scope. But when they have concerns, they have side effects, they're recognizing that the medication is not working. That's when we kind of jump into action and reach out to the primary care doctor and say, hey, the consult mentioned that we increased it to 50 milligrams and the patient's been on it 4 to 6 weeks, but it's not working. So there was a second option to utilize. What are your thoughts about that? So again, more involved in medications than maybe most of us have been in either social work or behavioral health. But it's been very helpful to treat the whole person. I can tell you in my own experience. So this is kind of when things pivoted and turned, and we had to take a step back and look at our model of care and look at the volume of patients and look at the acuity of patients as it related to the upsurge from the pandemic. Now, this chart here is from the state of Washington and explains about the ups and downs of symptoms that they saw in our population related to the pandemic. And you'll notice the pandemic started, I believe, in April 2020. Here's September 2020. We're somewhere around here in June 2021. But there was a definite idea that the symptoms were going to increase, that we were going to get new patients. The statistic I saw was that 3 million new behavioral health patients in the state of Washington. So definitely caused us, pushed us to really evaluate things and evaluate this model of treatment, evaluate where we're at in clinics, evaluate our volumes and that sort of thing. Just some other things, statistics from the pandemic. And these are national statistics here. The last one you saw from the state of Washington. On the ground, what we noticed is that we started having bottlenecks. So we, when we're building out a program in a clinic, we're sitting down with all the primary care providers and we're saying, this is a referral criteria that we'd like to start. And it might be typically over a 10 PHQ-9 or GAD-7, generalized depression or anxiety, typically not primary substance use. We tend to rule out psychosis type illnesses or mood disorders, PTSD. We can treat a little bit, but oftentimes if the patient's ready, we can move them on to specialty care. So we give the providers this referral criteria. And so as understandable, as time goes, we try our best to revisit those at meetings and talk to providers about, here's our criteria. But as acuity went up, as volumes went up, what we started finding out is that our patients were staying in treatment a whole lot longer. And so because we had higher acute patients, they were typically staying not 4 months in treatment, but on average 9 months in treatment. And that's around 40% of the time throughout our system of care. So that really provided a challenge for us trying to access the patients in primary care and make a difference for them, or try to get patients out to other mental health care providers, which was difficult. People filled up very quickly. Virtual care came out, so there was a lot of options out there, but oftentimes we couldn't get our patients there due to medical or comfort level or all sorts of different reasonings. But so really trying to figure out this bottleneck. So what we looked at doing is transitioning, moving from an academic to an ambulatory model of integrated behavioral health. And so one of the ways that we can pivot and adjust and adapt to the volumes and acuity of the patients that we're getting is really look at alternative levels of care in primary care. Recognizing that initially having frequent vetting of every referral would have been the best case scenario, but typically that wasn't workable. Typically we didn't have staff available to critique and review every referral that came in. So that was a difficulty as far as referral management. But that's the direction that we decided to go, moving from more academic to more ambulatory. And really what that meant is that meant investing in behavioral health as an organization. And that's something we really took seriously and recognized was coming and wanted to be ready for that. It gives you a little bit of a snapshot of not only behavioral health, but all healthcare, recognizing behavioral health needs as this pandemic started to affect people. You'll notice here the AMA wanting to commit themselves to having a sort of playbook for behavioral health needs for patients, to guide physicians through the barriers to successful behavioral and mental health integration. So this started nationally. They have a tool out there for physicians to really look at how to integrate behavioral health into their practices. So this really showed to me people were recognizing, they were noticing the importance of leveraging their resources in any way they could. So moving from academics to ambulatory was really kind of thinking outside the box. So one of the options and ideas that we have and we're looking at is psychiatric nurse practitioners, completing indirect consultations for primary care providers, being more mobile. Another thing that we did is that we aligned ourselves with PMG Psychology, which is a psychology outpatient clinic through Providence. And aligning meaning that we're joining them for case consultation, assuring that we're meeting fidelity to the model. We're practicing skills that are workable. We're looking at appropriate discharging. We're assessing, we're diagnosing, we're doing all of those skill-based clinical things that are important for treatment and for patient success, and also to assure that the model continues to do what it should do, is to help patients move on and either to being discharged back to the primary care provider or to a higher level of care, or sometimes even just to themselves. But that we recognize needing additional support. So we reached out to psychologists for that. So that is now set up weekly, where our LICSWs can reach out to psychologists and do case consultation, receive registry support, learn new and bolster existing brief treatment skill development, and also consultation training. So as far as patients that require consultation, patients that don't require consultation, really kind of getting a good sense of maximizing that resource. The other thing that we've implemented is a monthly training seminar, again, to enhance our clinical skills, to assure that the models of treatment we're working within are meeting their mark and aligning with the evidence. The next thing that we did, beyond providing enhanced treatment, aligning with psychologists, is really looking at recognizing that there are populations of patients that we can generalize to some extent that need a higher level of therapy. And one of the generalizations that we felt comfortable making was trauma. So one of the commonalities we saw with our patients is that there was a significant trauma illness profile throughout our community. And if we think about the pandemic and what that could create, potentially more to come. So the second thing that we did was develop a level 2 therapy inside the primary care clinic. And that's an individual that only does specialty treatment. And right now that individual is just doing EMDR, not just, but he's doing EMDR. So he's trying to meet that higher level of care. We can still provide the behavioral health treatment in the primary care, provided at a higher level, and continue that comfortable rapport building environment that patients have enjoyed. So that's the second thing that we did, is in one particular clinic, we're piloting this level 2 therapy. The other thing that we thought about is that in between patients, oftentimes individuals need additional support in the way of care coordination, in the way of meeting housing, nutrition, social outlets that they require in their life. So looking at potentially having a centralized care coordination team that can meet the needs of patients throughout the primary care when they meet a criteria based on the social determinants of health to need that support. So really being allowed to reach out to patients and provide those resources, provide information, provide advocacy, at times reaching out to connect and answer questions for patients of agencies or therapists or resources that they can utilize in the community. So that's another thing that we've looked at, is really trying to focus staff on specifically one expertise. So having our LICSW doing what's called the level 1 or collaborative care treatment throughout our system. And then having a level 2 or specialty care that can do the higher need patients. They'd have a lower caseload, patients would stay longer in treatment for them, but that could take up some of the bottleneck as far as the patients that we were recognizing were staying in our treatment longer and not allowing us to reach out to new patients and open up our access. The other thing that we thought about is there a way that we could have a live resource database that we would know the majority of behavioral health agencies and private practice services in the Spokane community, and we could know if they're available, if they're taking patients, what kind of insurance they take, their location, specialty treatment that they provide. And so one of the things that we've implemented in 3 clinics on a pilot is aligning and working with Quartet. which is a behavioral health concierge service that's already connected in Spokane with a vast amount of behavioral health providers. And they reach out to patients, and in essence, they do a warm transfer. So the patient gets seen by their primary care provider, and they would be a good match for treatment, but they have a higher level needs or specific needs like grief therapy or sleep therapy or pain management therapy. We can get those patients over to Quartet, and Quartet reaches out, connects the patients to the appropriate treatment provider that takes their insurance and meets their preferences. And there's no cost to our organization, and there's no cost to the patient. So that's another thing that we're piloting right now as an idea or a response to our increased volumes and acuity of patients. Also wanted to quickly touch on financial viability. Collaborative care, integrated behavioral health is billed. In the past, we have aligned ourselves with the COCM or collaborative care billing, which started in 2017 with Medicare, and then the next year in 2018, Medicaid started accepting that, and then commercial insurers have kind of come in behind that. But what we found in the past year, comparing just collaborative care billing, which is billing that requires the presence of a psych consultant, and it requires a model involving what we've talked about here today. Focusing on that, we build that through the entire pandemic. It's a different type. I'm not going to go too deep into the billing part, but what we found out through our analysis and data review is that doing a mixed billing service, so actually billing the individual for psychotherapy, which is exactly what we're doing during our visit clinic appointments with the patient. And then if we do additional care coordination between visits, we can bill the collaborative care minutes. So we have kind of a mixed billing platform here. And so we found that to be more financially viable than just leaning on the collaborative care billing. And I think part of that is just exposure to the billers in the community, just comfort, knowledge, knowing about it. They say that typically commercial insurers take about 2 years to learn about what Medicare and Medicaid are doing. And that seems accurate in this case, maybe even a little bit longer, but that's what we found to be the most effective, is a mixed billing. We also do other things in primary care besides the treatment of patients. And that is really a part of the model of treatment that we're providing that's so important. It's so specific to primary care. Yes, we can make an impact on patients' behavioral health, but there also will be opportunities to make impacts within the moment support. The patients that come into the doctor's office and are having a difficult time and need a referral to grief services or need a risk assessment. These are things that our staff do in the primary care. So it just gives you a couple examples of what we've done here recently. Mindfulness training for staff during the pandemic was super successful. There are specific mindfulness trainings for healthcare providers, which were really helpful to help the staff kind of digest a lot of what was happening in the pandemic. Primary risk assessments, resource referrals during risk, safety planning, trying to decrease ER visits, outreach to patients during COVID. We did a lot of that. That's turned down a little bit, but we did a lot probably 6 months ago, just to check in to see how they're doing. Like I mentioned, doing risk assessments in the primary care when people are presenting with risk to self or others. Just a little example, number 5 of one thing that we did with a 13-year-old. And then talking with primary care providers about establishing rapport. Patients that have higher affect, at times agitation, they're really struggling, sitting down with providers and talking about what we see to work, and communication styles. And so that can also be a benefit. And so we look at fee for service and financial viability, but there's also the value-based care. And I think likely that's where our field's going, is maybe away from, that's just an idea, but maybe away from fee for service and toward value-based care. And the important thing of looking at value-based care is, what are the things and ways we can impact patients outside of traditional appointments? Traditionally, one thing we recognized is that despite our abilities to provide referral algorithms, referral criterias, what we were noticing is that everybody was coming in. Severe, mild, moderate, even sometimes 1 appointments, regardless of what the need was, which was helpful. But if we're trying to make a bigger impact and a larger footprint on the behavioral health profile in the clinic, it was important that we narrowed down and provided specific access to specific treatment that is more workable and can provide faster results. So other conditions, medical conditions, go under chronic care, right? They are specific. They match level of acuity. And I don't know you all's experience, but in behavioral health, sometimes it just becomes a wide open door. And so just like the medical community does, I think it's important that we match the care with the level of acuity. Early intervention, screening, access to care, outcome treatment with the registry, accountability, measurement, that sort of thing, so that we really can provide a good picture through data analytics to understand where our population is at right now and what their needs are and what treatments should we leverage and which can we back away from a little bit. Traditionally, options, medication management, talk therapy, inpatient residential treatment, but how do we become more specific? And I think that's something we've learned through this pandemic, is how do we provide options for our patients and get them to the treatment that's the most successful at the earliest time so that they can feel better faster and that we can help the next patient. Multi-layer clinics is along the same lines of just what I'm talking about. If you think about having multiple layers of behavioral health support services, even in a primary care. So recognizing that at the time that somebody sees their doctor, that if they're struggling, but they're kind of thinking about counseling, but they're not quite ready, they still want to think about it. Hey, there's Silver Cloud. That's an electronic, evidence-based computer platform that the person can work off their phone or computer and get education and work on skills that help for depression and anxiety. So that would be potentially the lower level treatment. Level 1 would be the integrated behavioral health, the model that I had talked about, the collaborative care. Level 2 would be specialty care for specific illnesses like trauma, potentially OCD, but that hasn't been looked at yet. But so right now, looking at the trauma component that we tend to see a lot of. Another option that would be a level of care would be a team-based care model, which would be in the moment, shoulder to shoulder with the doctor, meeting with patients on a regular basis, day to day, and potentially referring them back to be seen a couple, 2-3 times, but only no more than that, is providing that brief 2 to 3 visit treatment where they can get some skill development and then have referrals for longer term treatment if that's something they're interested in. But we have clinics that have long waiting lists, and we have clinics that we're piloting a lot of these things on to try to figure out kind of what works, what doesn't work, and really looking at the access point. What's the best model of care to improve access? Referral management is a big deal. Like I talked about, sometimes difficult to get the staffing to do that. We've leveraged at times interns, level 2 therapy with psychologists. So developing direct referral abilities to Providence Psychology when they need the higher level of care. And then I want to give us some time for some questions. So I just put a little quote here at the end. Just because no one else can heal or do your inner work for you doesn't mean you can, should, or need to do it alone. So any questions out there?
Mark, I just had kind of a question or point of clarification when you were talking about the billing piece and how you were able to do kind of the combined billing. Was that specifically for Medicaid, and are you looking at how to do something similar with private insurance?
No, so the collaborative care billing, which is what we started out in 2017, when Medicare recognized this model, specifically collaborating with physicians and the presence of a psych consultation. They agreed to start paying for that. But you had to have those components in place. In 2017, 2018, Medicaid came, and then commercial insurers have trickled to the table, although it's been a really, really slow process, and it's kind of a hit and miss for payers that will accept it and ones that won't. But what we decided to do is really recognize that collaborative care piece, a lot of it is about the care coordination. Yes, we're doing skill development. Yes, we're doing treatment, cognitive behavioral therapy, but the care coordination piece is really the in-betweens, the supports with indirect psychiatry, with contacting family members, with contacting other professionals in the community and resources, but recognizing that we're going to maintain psychotherapy because it is psychotherapy. When we're doing these visits, we're doing specific skill-based work. Now, outside of the visits, we're doing more care coordination. So we're billing both. We're billing the psychotherapy, and if a patient gets coordination, not all of them do, but if they do, and they meet the threshold, then we can bill for that collaborative care, those minutes at the end of the month. And so that's what we found to be the most beneficial and the most matched with payers out there. hopefully that was a answer to your question. I tend to talk a lot, so.
That was helpful. Thank you. The other question I got in a separate chat was about if you have started working beyond this lunch and learn, or if you've considered how to kind of provide technical assistance if other organizations are interested in doing this, about some of the specifics around the coding and billing, or what works, or sharing workflow documents or something like that.
I haven't considered that to this point. We tend to work regionally, so lots of times I'll reach out or have questions from other regions within Providence, such a big organization. I haven't yet thought about that or that possibility.
Any questions from attendees that didn't send me in chat? All right. Well, thank you so very much, Mark. This was incredibly informative, and we love hearing about the good work happening in our partner organizations in the community.
Absolutely. It was a pleasure. Nice meeting everybody.
Right. Thank you so much. And we will send out the slides and recordings to folks after the meeting. And if you have any questions, things that you think of afterwards, please let us know and we'll get them on to Mark. Hope everyone has a good afternoon.
Yeah.